through the rules in a minute for the debate. But as you know, we have a topic and you have it in your package. And I'll just read it to you so you remember. Is it be it resolved that we have the health data we need, we just need to use it. So the debaters on the positive are Kim McGrail, and I'm not going to give you their big bios. Most people know Kim. She's a healthcare researcher, and she'll be part of the positive. And then to her right is Dr. Goldis Mitra, who's a family physician and does some work at Surrey. So she and I are now new BFFs since I'm spending a lot of time in Surrey. And to my left is Glenn McRae, who's a CNO and VP of Quality at Interior Health. Okay, that's part of the rules, none of that. Because we are not going to have fun during this debate, remember? And to his left is Hugh, and I want to make sure I get your last name completely right. Okay, you're not on my paper, so you're just Hugh. No, you're Hugh Alley. I'm big silly. A patient partner, a member of the Patient Voices Network. So there's always a couple of disclaimers in the debate. One, they didn't get to choose their sides. Two, this is not a gender issue here. So for all of you that are making comments, not my choice, Andrew made them do this. So so here are some of the rules. So because we're Canadian, isn't that a wonderful thing to be able to say?
Yeah.
We conduct this debate quintessentially Canadian. Nobody wins, except maybe. So nobody wins because we are Canadian and we're proud of it. Now, having said that, you all know that once the gloves are dropped, the elbows come up, but this is a no contact debate. So they are not allowed to actually have contact. I might actually with them if they don't behave. And trash talk is allowed quietly. Don't do it when your mics are on because people don't like that. They frown on those types of things. So there are rules around the debate, and there used to be winners, but now we have on your table or on your app or somewhere, somebody is going to tell you how you actually, and I don't think we can use the word vote, how we indicate what your position would be now, whether you're for or whether you're against. And then at the end, when we all sing "O Canada," we will actually indicate who actually moved the dial the most. So the most important rule in this, and this is where our friend Andrew gets chest pain, is keeping to the time. So we have a clock that is so gigantic you can't even imagine. So my job is to keep them on track, and you can tell I talk too much, so they're trying to keep me on track. And one of the things that I pay attention, and then last year, I think some of you might remember, we had a foam pit underneath that, and so you got the hook and you fell down. WorkSafe BC didn't like that. We're not doing that again. They got cards and letters from them, not good. So what we're doing this year is I have a very subtle way of saying the word that ends with shut and you know what the other word is, and it's wait, W-A-I-T. And you're thinking, oh, do I need to wait? No, why am I talking? So if I say wait, you're kind of getting the hook around that. So in the spirit of that wonderful woman this morning who said we're supposed to have fun, I thought we would do is we ask the debaters to sing their submissions. They could spend the first 2.5, and maybe you would dance. I'm not sure. I was trying to figure out how to take, because data is, there, see, look, and you're on that. You can, but we need music and might eat up too much time. So back to the question, be it resolved, we have enough data, we just need to use it. This group, the women, not that we see gender, are arguing for, and the gentlemen are arguing against. So I think without further ado, we'll begin, and I think we're beginning with you, Kim. Is that correct?
That's correct.
Okay, sorry, I missed that. Oh. Ooh, pretty tight. Yeah. This could be a very tight debate. Okay, so, sorry, I forgot that you had to put that up. Okay, Kim, over to you, my friend.
Great. Thank you. Good afternoon, everybody. We spent just about $55 billion on the BC healthcare system in 2024. That means that today there will be $150 million spent on healthcare, or $6 million during the hour that we spend together. I am receiving none of that. On average, every day in BC, there's almost 1,200 people admitted to hospital. There's about 8,000 people in an acute care bed. There are 1,500 day surgeries. There are 115,000 physician visits and about 285,000 prescriptions filled. All of these encounters and many others as well generate health data. There's information on who was seen, what was done, the purpose of a visit, and we can connect services to people over time and across different kinds of healthcare use. We can connect all of that to an age, place of residence, estimate of neighborhood income, and immigration status, and that still is just scratching the surface. We have lots of data. Are there things missing? Yes, of course there are things that are missing. But we can't let the perfect be the enemy of the good. Voltaire was the first to say that. Those French guys really have a way with words. So using the data we have done right can prevent harm. Not using data causes harm. And yet for all the data we have, our system lacks transparency, even for simple things. I would give a shout out to PHSA for providing some information on chronic disease rates and experiences. But where's the information on the composition of primary care teams, who they're caring for, what they're doing, and what's up with UPCCs? What's the mix in services and costs for people at the end of their life? And how many frail people are living in communities without all of the supports that they need? Without data and transparency around data, there's no real possibility of accountability. And by accountability, I mean the system's accountability to the people of British Columbia, who are the ultimate payers and owners of the system. Using data improves data. Using data improves the capacity of people to make evidence-based decisions. Using data and reporting on it increases transparency, which is a key ingredient of trust. Then we need to act on the information to make system improvements. Here's a couple other things Voltaire said. Opinion has caused more trouble in this little earth than plagues or earthquakes. And those who can make you believe absurdities can make you commit atrocities. Maybe it's a little too soon for that. It's time to remove our blindfolds. Let's use the data we have.
Thank you. Look at that. If there was a time winner, you did it. Okay, Hugh, over to you.
Madam Moderator, ladies and gentlemen, there are reams of unexplored and unanalyzed data. Unfortunately, the data we have is so incomplete and so misleading that we would be fools to proceed on improvement efforts without more and better data. Let me talk about it from a patient's perspective. First, the data is incomplete. It doesn't measure what matters to patients. We care about whether we can go home and get back to our activities of daily living. Can I go back to work? Can I climb my stairs? I don't care if I get out of the hospital a day early if I can't go shopping and I don't have the supports I need in place. No one has ever phoned me after a surgery to ask, how are things going now? Second, from the patient perspective, much of your data is misleading. Let me give you an example. My wife had surgery. The morning of discharge, she felt faint. The nurse said, your husband can get a wheelchair. So I did. And at the street, I went out to hail a taxi and got back to my wife, who had slumped unresponsive in the wheelchair. I phoned the ward. You'll have to take her to Emerge, she said. At Emerge, she had a 4 to 5 hour wait, and the day was saved when the unit resident happened to notice she had been readmitted, and he came down and said, what's up? So we explained, and he told us to give him a moment. 5 minutes later, he came back, having looked at her blood work. He said, I'll discharge you. You'll be good to go. And she was. Now, here's what your stats tell you about that trip or that visit. You got to discharge a day early. Hurrah! And the ER saw and discharged a patient in 2 hours. Hurrah! The system performed. Not a chance. The system botched the discharge, stressing my wife and me. And your data doesn't capture that. It doesn't get the patient experience. In my working life, I'm an industrial engineer. I fix processes so it's easier for people doing the work and better for the customer. I helped a lab cut the waiting time for their patients in half without adding people or equipment. You know what we needed? More data. We needed to collect daily data where the work was done, because in the end, improvement is local. To improve in a good way, we need more and better patient-centered data.
Thank you, Hugh.
Absolutely.
Hold it.
So luckily, I have a good news story, and it's that we have all the data we need here in British Columbia. We have treasure troves of billing data. We have mountains of data in our electronic health record systems, Cerner, Meditech, PowerChart, not to mention the 20-plus office-based EMRs. The bad news story is that these data are not easily accessible. This has a huge impact on clinicians, on health leaders, and on the public. It's because none of us have the access to consistent and straightforward information about patients, so we can't provide the patient care we need to, we can't make evidence-based decisions to improve our health system, and our patients can't hold the system accountable. For clinicians, information about my patients lives in so many places it makes it almost impossible to use. When I'm at the hospital, Lynn, I'm admitting a new patient, I need access to their history, their tests, their visits with other doctors. There's no central document, a patient summary that would give me an idea of who my patient is medically. We don't have the interoperability for that. And remember that to most clinicians, interoperability doesn't mean me having to open up another browser window, put in a URL, then go through two-factor authentication, and then promise my first child to anyone who will show me the results of my patient's CT scan. Think of the delays and the time that's wasted when we don't have seamless access to the information we need about our patients to care for them. The information exists, we just don't have the access. At the same time, leaders working in our health system, including those all the way at the top, they don't have access to the aggregate data they need to make evidence-based decisions about our system and to improve it. Why? Because we don't have agreed upon ways of storing and using the data that we already have to make rational decisions about a system that we are spending billions of dollars on. And of course, if leaders don't have access to those data, neither do the public. And they can't ensure accountability for those billions spent on healthcare. The public, they deserve access to their own health information and an understanding of how our health system is functioning. The opposite side, they're going to argue that we need more data. I would love more data. Kim would love more data. No one's going to argue with having more data if we had unlimited resources, but we don't. And so we need to focus on accessing the incredibly rich data we have and using them properly. Thank you.
Thank you. Over to you, Glenn.
Thank you. The resolution, however, is that we already have all the data we need, not that we need more. So it's that you're saying we already have all the data we need. And prior to today's debate, I had a chance to go through the exhibition hall, and I assume many of you did as well, just to have a look and see what's there. And there's 137 different stories and poster boards, every one of them rich with data. Most of those data developed through primary data collection, because the team trying to do the improvement work didn't have the data they needed. They had to go out and create it. That's how healthcare works. It's how it has to work. There's board members and executives and many people in the room who are familiar with the hospital harm measure through CIHI. That measure comes to us quarterly. It looks at the level of harm in our hospitals, and it's about 1 in 17. And we get it 6 to 9 months after the care happened. It comes with disclaimers such as, these data are not risk adjusted. Please don't use to compare them. These data represent just a small sample. These data shouldn't be used to guide improvement. And then Healthcare Excellence Canada has guides for each and every category of harm that shows up in the hospital harm data. And their first step in each and every package is go do a chart audit and generate more data so you can understand what's actually happening in your system. So we can take the expert advice and go generate our own data and continue to generate our own data and new data, or we can just wait 6 to 9 months, use the data we have to see if the change we made today actually made a difference. So also I will say that simply using the data we have is guaranteed to perpetuate the historical and systematic and societal inequities we have in our data. Those data fit better for some people than others. They work for old or older,
Yeah, watch it.
white, cis male men of European ancestry. Others, equity-deserving groups, are not represented in our data. They're absent. So continuing to use the data we have is going to perpetuate this systematic and systemic inequities in our system, because at the end of the day, the data we have were put in place by people working in the system who had a societal privilege. So the data work for some people and not for others. So I would say we need data that are reflective of our whole society, and the current data simply are not enough.
Thank you. So I think that was a great first round. So the two of you have the first chance at rebuttal. And if you don't, then boy, I've got lots to say. So what do you think about, there are two gentlemen over here.
Yeah, I think we've entered the chicken and egg part of the debate here. And the question is whether we should prove our worth by using the data we have before going out and getting some more. So my quick anecdote on this is I was getting ready to do a public deliberation on health data use, as it happens, and was speaking with a legal counsel for a group that works with people on the downtown east side. And I said, I'd love for you to come and talk to the public about data use. And she said, hold on a minute, Kim, I'm not sure exactly what you think I'm gonna say, but you have all of this research that shows equity implications of healthcare services and all of the problems that different groups experience. What have you done to fix that? And why should anybody trust you with more data until you use the stuff you already have? I've taken that to heart, and so I think I'm on the side, I don't know whether it's the chicken or the egg, but I think we have to use what we have now as a way to build trust and earn the ability to collect more.
So where are the two of you in the chicken-egg debate?
So I'll start with the fact that I'm an industrial engineer and I look at processes every day about how do you improve them. And the thing you need if you're going to improve process is actual live process data, not outcome data, but process data. And I'm an outsider, but my understanding is there's not a lot of process data in what we have. As our opponents indicated, lots of what service was done, who was it, when was it, how long was it. I used to work for the WCB, and there were doctors we knew from our data who performed worse. Their patients suffered disabilities, permanent disabilities, at a consistently higher rate than their peers. We knew why. We could not share that data, but boy, it would have been nice and useful for the patients. And frankly, it would have been useful for the doctors who were doing that work, because we could tie process to outcome in a very important way. And that's a piece that I just don't think is being addressed by using the current data.
So Goldis, do you have a comment?
Yeah, you know, I appreciate these delays. There are huge delays sometimes in being able to get electronic data over from one system to another. There are certainly, you know, impacts on patients, but like we know we have multiple hospital-based electronic record systems here in British Columbia. They don't always talk to each other. So for example, if I have, you know, something really important for a patient might be a report about their echocardiogram, so an ultrasound of the heart, right? If I'm in my North Vancouver office, I can't get that a report that's generated in Island Health or Interior Health through Care Connect. Care Connect's supposed to connect all the care in BC. Instead, I have to ask for it to be faxed over, and sometimes that takes days. That impacts patient care, and so better access, really, really important. Interestingly though, on the International Space Station, they have an ultrasound machine. And so astronauts all the way up there can ultrasound each other. If they run into trouble, images get transmitted down so they can be analyzed by cardiologists. So Houston can literally look at ultrasound images from space, but in North Vancouver, I can't view an echocardiogram from Kelowna. Before we spend more money and time trying to get more data, let's use the data we already have and use it better.
So Glenn, you gotta pull them out of here, come on.
Yeah. So as a former chief nursing officer in this province, I have questions about scope of practice with NASA that I think need to be addressed.
I agree.
But I also have, you know, I respect you and your work, and I had a chance to look it up, so, Dr. Mitra. So I know one of the things you do amazingly well is work in the primary care space. And I know there's data everywhere, and if the data were available and it was just interoperability, you, with your work with Our Care, wouldn't have had to go out and create the largest new data set of primary care data ever produced in the country. Your team, a team you're part of, went out and they interviewed 10,000 people.
Over 10,000.
They created numerous town halls, additional information. They ran focus groups, all with the hope of generating new data. And out of those new data, not the existing data that you just didn't have access to, came a brand new provincial standard or national standard around how to support primary care. And I suspect the way we're gonna know that standard's embedded is going out and generating data about the uptake and the implementation. So I know you agree with me and you were put there by accident, so thank you.
Well done, well played, actually. So I have a couple of questions. I know that'll surprise you. So to the examples that you folks have given, what I'm hearing is there's tons of data, tons and tons. And then we have our learned colleagues say we should generate more. So if I was a member of society, oh yeah, I am at times, I would say, so why are you not, actually, to your point, is looking at what you've got and applying it in a different way. So when you were telling your story about your wife, and I'm sorry to hear that, I thought, at least you got a wheelchair. Bad response. I mean, because the data would indicate that we're in to build yourself a wheelchair. Because, so I know, isn't that terrible how your mind thinks? I thought, oh my God, Lynn, that's not good. But I would not suggest then we collect data on whether wheelchairs are available. And I think perhaps that's part of the issue here. Do you have enough? I don't know. But we're continually generating more. And then we argue about, well, I'm really on Tuesday, it doesn't look like that. So how do we get out of that? So, so you're very familiar, way more, certainly Kim and Goldis and I, and with the data. How do you get out of that? How do we stop collecting data? And the goal is you got to use what you've got.
I mean, I think, I appreciate you bringing up Our Care, the largest ever study of how patients want changes made to our healthcare system, to our primary care system. One of the major findings out of Our Care was patients said overwhelmingly across the country, no matter where they lived, I want access to my patient information in a central place, in a place I can easily access it online so my providers can see it as well. Because right now, Patients are going through the system, they go from one place to another, relating their histories over and over again, and it's such a burden on patients who are complex, who have chronic disease, recurrent admissions to hospital. And if we put the data back in patients' hands, if we made the data better available to clinicians, to health leaders, I think that becomes a first step to seeing some of the results in the system we want to see.
So I think Chris's example about himself this morning is it wasn't to the clinic, it was to him. So what do we do here that you cannot access your own? So you've got data about me or data about my family and you can't get to it. So is access the issue or is data the issue? Or is the information out of the, I mean, I think we all as healthcare, we're worried someone's gonna make something up when they see their data. Well, they might actually, and they kind of get to do that. So Glenn, I could see you when Goldis was talking. So what are your thoughts, what she was saying about how, you know, across the country, folks are doing things?
Yeah, I mean, I'm a fan of value add. And so if there are data out there that aren't useful or usable or are blatantly incorrect and missing the consideration or contemplation of groups of people that the data are being used to support care provisions for, I think those data need to be deleted or modified. But that in turn creates new data. Yeah. And so we don't have what we need more. At the end of the day, we have a complex adaptive system. We've heard that probably 5 out of 6 lectures people are at so far used complex adaptive system or complexity or this or innovation. And that means the healthcare system and the way we provide care continues and continuously evolves. If you think about virtual care, what's the data set from 10 years ago that would inform how we evaluate the effectiveness of virtual care delivery today? It doesn't exist. So we have to evolve the data and the use of data with the way we evolve the healthcare system. And I always partner myself with a patient because they can say things you can't, and they can also tell you things you don't know. And that's a huge opportunity for us. Those are data that are somewhere, but we don't have good access to it to add, you know, to complement the point you were making on the other side for 4.
So Hugh, I wanted to ask you, you're talking about process improvement, and I would think here in this province, there has been an enormous amount of time and effort doing process improvement. I mean, we all, when you're my age, you remember all the, so has that actually improved though, the whole point of this conference, which is patient safety? So you can have, here's me, sorry, brilliant processes that are more efficient, more effective, and the outcome is more efficient, more effective. So that's where I'm struggling a little bit with that part of the argument.
So you can use the data that we have is, you know, barring the issues of completeness and bias, the data that we have is very helpful, and Golda talked about it, of being able to assess some of the big issues of how healthcare needs to adjust and adapt. As you drill down, because it's all very well for the ministers to say, we shall, but how does that show up on 5A? And at the level of somebody doing work, you have to somehow translate the big system into the small system. And the only way you can do that is with local data that's current, collected, that the people doing the work have responsibility for. And there, thank you. I spend my life working with frontline leaders, and I deeply understand that 75% of the improvement ideas, given an objective stated by management, the actual ideas for how to make it happen, those come from the nurses and the cleaners and the x-ray technicians and the phlebotomists, right? They're the ones that know that work. And that's where the improvement happens. And yes, we can have big picture things that say whether we should have primary care centers or more family doctors or whatever. But when it gets down to actually making it happen, you need that local stuff. So at some level, I totally agree with what.
Broke the rules of the debate.
No, but you see, I agree with their statement that there's a ton of data that we don't analyze very well, and we have real problems analyzing. But even if we could, it wouldn't be enough.
Yeah. So to your point, though, and over to the ladies, when you analyze the data, so data, that's numbers. We've got 5 truckloads full of that. How is it the analysis is done so that actually it's usable and not 9 months later? Who's asking the questions of the data? That's usually, you're a researcher, and I say this very respectfully to researchers, and you're interested in all kinds of stuff, which may or may not be what we're interested in. So how does that work? We have all the data, we just need to use it. Is it usable? Is that a word? For the things that Goldis is talking about. And I am going to put you a bit on the spot, Kim. So what would be your lived experience? You do all this work, you have all this stuff, and we look at it and go, nah, no, that's not going to work for us.
So how do we actually make good use?
Yes, or how do you even decide what to collect? Like, I think to Hugh's point, who are you involving in? It would be really interesting to look at, I don't know.
Yeah. So, I mean, this is the way that we're moving, is this whole strategy for patient-oriented research. Like, the questions need to be driven by people who are experiencing the healthcare system, people who are working in the healthcare system, from people living in community who know what the problems are. The questions have to be driven from there. And the outcomes of interest have to be driven from there, too. So it's not enough to say we know what the question is. We also have to value what people tell us that are the outcomes that really matter. So in that context, would we have all the data we need? I don't know. It depends on what's being asked, but we could at least get a start on things. We could define some problems. You can take geography and drill down into local areas. You can, and then what you can do is you take your big kind of conceptual idea of the things that might matter to the questions you're asking, and abstract from that the things that you can actually address with the data you have, identify the gaps, and then go work on them when you have additional time to do that. But letting the perfect be the enemy of the good when we know that there's so many issues and we have not been asking the right questions seems like a big loss.
Yeah.
So I wanted to get to the smattering of applause, Hugh, that you got about point of care. Theoretically, there wouldn't be a person alive, sort of. Maybe there might be 2 that don't agree, that would do that. And I remember, and I'm looking at my friend Christina Kraus, when we were doing, was it surgical site? We were doing something in the emergency department. And you had the multidisciplinary team, and they were going to gather data at point of care, except the point of care people are busy doing point of care. And I remember it was sort of, well, they'll fill out this. They won't. But what was the one? Sepsis, there you go. Very important. So somewhere between, I've got a job to do and I'm collecting data for you, I'd be interested in your thoughts about that, or Glenn, yours, just in terms of if we need more data and we think it needs to, quotes, more relevant. I'm making that up, but.
So it's really easy to develop a data collection industry.
Yeah.
And that's not what we want.
Yeah.
But usually, if you're trying to solve a specific problem, at any given moment, you don't need to be collecting large numbers of data points. I'm working with a client right now, not healthcare, but they have 3 data points they need to capture each day. That's not outrageous. People waste that much time in their day.
Yeah.
And that's enough for them to chart how they're doing daily and to see whether the experiments they make every day are making a difference to the outcomes.
So is that where Kim's point about perfection getting in the way of good enough starts to actually?
Oh, yeah. So you define the big level problem from the high level data that we have, and then at the local level, where you have to decide how your shipper receiver places the shipment of goods for the hospital. That needs specific data that doesn't take a lot of time. And the minute the problem is solved, let's stop collecting that data.
So there's an interesting concept, isn't it?
Yeah.
So I think we have burgeoning data sets. Somebody asked this morning about prems and proms, and nobody alive knows whether it's being used or not used, but to your point, I'm guessing it's still being collected.
Yeah.
Which is back to the value add. So I'm looking at my clock here, and I don't know whether to give myself the hook or... Pardon me? That's what I thought, so I'm looking at the clock. Okay, so we've got the back and forth. You each get a minute on the clock.
Okay. The
Kim.
thing we need to do is to fix the data foundations. And part of that is about culture and having a data culture. Everybody in this room is doing quality improvement. I think you get this, but I would bet that you don't feel that the whole of the system is where it needs to be in that regard. Second, we have a health data charter, a Pan-Canadian health data charter, which actually will help us define the data foundations that we need. This has been signed on to by BC. We have made the commitments to it. We need to actually put it in place. And that includes things like person-centered data design, person's involvement in the design and oversight of the use of data, distinctions-based relationships with Indigenous nations, and a real commitment to supporting and respecting Indigenous data sovereignty. Access, privacy, interoperability, all of those things are in the Health Data Charter. If we can do that, we'll fix all the issues that we have.
Ooh, in 1 minute, that was pretty damn good. Okay, Hugh, no pressure, but over to you.
Madam Moderator, ladies and gentlemen, at any level below the Vice President, improvement must be described in terms of behavior, not dollars. There is no cash register beside the bed, just behavior. To improve, we need data there, outcome data, and process data. A friend chairs a society that runs a small residential care facility. He gets reams of government-mandated data every month. None of it is actionable. It's not granular enough and not process-focused enough for his team to know what behavioral changes they need to make improvement. Improving our healthcare system faces many obstacles. One is the dearth of actionable data, process data that must be collected and wrestled with by the people doing the work at the point of delivery. They'll need more and better data, patient-centered and process-focused, to improve the system. Thank you.
Thank you, Hugh. Goldis.
There's no question we have all the data we need here in BC. I think the more relevant question is, how do we use it, and how do we use it better? We all deserve consistent and straightforward access to data and health information. And so you heard how clinicians, doctors, nurses, everybody working in the system, we need better access to our patients' health information so we can provide more efficient and effective care. We also need better scale and spread of practice-level quality improvement tools like the Health Data Coalition that can allow us to do some of that local data work. And while clinicians work with data, they work to improve that data over time because they realize, oh goodness, this isn't showing up all that great in HDC. All right, let's fix it. Health leaders need access to the big picture data. They need to make evidence-based decisions about our healthcare system and to improve it. And patients, they need access to their own health records. They also need transparency and to be able to understand the ways in which our system is working and the ways in which it needs to improve. We don't need more data, we just need better access to it. Thank you.
Thanks, Goldis. Sorry, Glenn, I ran out of time. You can't.
Yeah, that's
go.
fine. Should let the patient go last because then he gets all the
Almost
time
last
he
word
wants.
to you.
If healthcare is an infinite game and it doesn't have a stop and an end point, how can we at a certain point just say stop? We have enough data. We have enough data to understand the future. It's infinite, it's gonna keep going. My first job in quality 20 plus years ago was as a quality nurse. And I said, thank you, because I've been telling everybody I was a quality nurse for a long time. Now I had a title and I had a badge. And they gave me 20 individuals who were to support primary data collection at my hospital to generate new data to help us pass accreditation. And then when we passed accreditation, they got rid of my 20 individuals and we lost the data we needed to make improvement. And I know, Dr. McGrail, you agree with me. And because recently, just last year, you and your colleagues published a research protocol around a new model of substance use being done here, substance use treatment being done here in Vancouver. And what you said is the current data are inadequate to help us understand the issue. And that what we should do is spend time and energy on new data collection.
Well done, Kim.
At the end of the day, I implore you all to reject the ridiculous statement that we have all the data we need. Clearly we don't.
Well played. That was very well played.
That's why I don't publish anything.
I know. And no, Kim, you don't get a rebuttal. I think your blushing says to me he's halfway accurate of what he said. He may have taken it out of context. People are always quoting people out of context, but I thought that was very well played, Glenn. So I think this is coming to the end of our debate. I think that they have done a very good job. My friend Hugh almost got the hook, but he managed to recover. And I didn't need to haul out the wait word. So I think we should actually give a huge round of applause. And like any debate, you know, you pick and choose. There was at one point, Hugh, I thought, you forget what side you're on, buddy, because he was over here. And I think, but that's because these are not binary topics. You know, I mean, we always make them binary. It's either is or it isn't. And I think that the cross conversation likely is kind of the tipping point where we are. We have lots, we're not using it very well. We could have better, and I think that's the point, have better. And I think Hugh, your part about the point of care. But I would actually ask all of us to think when we say we need more data. So I've been at the Fraser for 15 minutes, and every time I go somewhere, they need more data. And we've got wheelbarrows full of data. I'm not sure how we're using it, and all the reasons why it's not perfect. I think sometimes we just need to get on with it. So we're gonna have another vote, but don't remember, you know, nobody's gonna win, so we're not gonna do that. It's have you changed your mind from and it was pretty darn close, the for and against before. So if everybody would actually do their little vote thing. Ooh. Huey, I think it was the wheelchair. That actually got all of us. We were so impressed that your wife got a wheelchair that. So the people have spoken, but you're not a loser because we're Canadians. So I don't want you thinking that you were. But another round of, this is not easy to do. You know, this is not easy to do. It sounds easy, and for me, it's always having that on the big screen. I said, you know, if you look like Goldust, it's gold. If you look like me, oh, really? I don't want to look like that. So thank you, you guys. Good sports, good team players, and thank you both. Well done. Thank you.